Right, welcome to Way2PACES free sessions. And today is the session about station 4, communication skills. The scenario we are talking about is 85-year-old Garry Thomas. Way2PACES free sessions. And today is the session about station 4, communication skills. The scenario we are talking about is 85-year-old Garry Thomas, Way2PACES free sessions, and today is the session about station 4, communication skills. The scenario we are talking about is 85-year-old Garry Thomas, Way2PACES free sessions, and today is the session about station 4, communication skills. The scenario we are talking about is 85-year-old Garry. Yeah, okay. Is it fine now? But I hope it's fine now. I'll repeat, I'm so sorry for that. So
yes, I can hear you now.
Glitch.
Yes.
Okay, 85-year-old Garry Thomas, who was admitted with a back pain. He has carcinoma of lung, and investigations revealed multiple bony metastases. Clinically, it's not appropriate for any oncological treatment. He was referred to palliative care with his consent. Garry asked the doctor about the prognosis, and he was told as likely to be short weeks. Later on, he was distressed and called her daughter, or his daughter Sarah. She's here to meet you and answer her concerns. So we usually go with the timing and then do it over there. So in this case, we can have a little bit of workout. So what do you think the primary issue is here, Dr. Noah? When you get a scenario like this in the exam, in the 5 minutes, so what are your thoughts?
Yes, so I would go to discuss with her the palliative care and the end-of-life care as well. The comfort care, we are aiming not to cure the disease, rather than we are going to ease the symptoms and ensure about the comfort of the patient that need end life.
Are there any other issues here? One is you're going to explain the palliative care to his daughter. Then anything else is going on here?
Yes, I would share with her that in the meantime, we advise to share with us his wishes in the future, advance directive.
Right, so you can't find any other problems or issues here.
Mm-hmm. So this will be my main topics to.
Right. So this is the usual structure is. So get into the thing. Okay, not appropriate for any treatment, extensive bony metastasis, palliative care referral, explaining the patient. That's okay. But why the line says he asked the doctor and he was told as short weeks, and later on distressed and called his daughter Sarah. That means what?
Maybe he's concerned about the short expectancy for his condition.
And do you think any other concerns from his daughter Sarah? Anything can be told about this?
She may be raising why you inform him about this condition, and that's the we will inform her that is our duty to be open and honest with the patient. Yeah. We have the right to understand the medical problem.
That's the thing I would say. See, that's the thing. See, before addressing this issue, I don't think you can go back discussing about palliative care and comfort care and all. So that's where we need to look into the key features about what is happening over there. I'm going to mute all. You can unmute Dr. Noah. And people, please make sure you mute your thing except the participant, Dr. Noah. Thank you. So the first issue is, I don't know how the surrogate would be. So people, it depends on what the surrogate wants to discuss with you in terms of relatives. Okay, why did you tell him First of all, why did you tell him? And that's making him more distressed, because those are the clues here. He's distressed and then called his daughter, and immediately after telling about the prognosis. That might be the first issue. Then the next thing is about why you told, and then if you cross that bridge, the next thing is about palliative care, comfort care, and then referral and everything else. Okay? Right. So this is how the reason for me telling is to just prepare yourself. So this is what it's going to be. And then once you know what is what, in the 5 minutes, you can discuss all these things, and then you can rattle about the what are the legal issues here, ethical issues here, collusion. And then if the family says, don't discuss with the patient, how do you respond? So all these things you need to be ready. And what do you think the emotion side from daughters? What type of emotions you're muted.
Sorry. So initially she may be angry about informing her dad about the prognosis of the condition. Then later on, she may accept our management and may enter in grief or sadness.
Okay, right. So when you're ready, we'll start like at 12 minutes. And then before 2 minutes, I'll give you a warning. In 2 minutes, I'll stop. Today, I will give you like a 1 minute for the thought process. And then we will have another 5 minutes with the examiner. And after the session is done, role play is done, we'll discuss any questions or anything on that. Okay, so we'll do exactly as in the exam, including the 1 minute thought process time. So during the thought process, I would say the listeners as well, if you can, this is the right time, I would say. So don't worry about, okay, the participant is doing, we can listen, don't do that. That's my suggestion. Just get a pen and paper, and then you think what are the things you say, and then write it down. Then only you can travel, even though you're listening, you travel with the scenario, and then you gain more. Okay, start.
Hello, my name is Dr. Nawar, one of the physicians today at the clinic. May I confirm that I'm talking to Mrs. Sarah, the daughter of...
I am Sarah, but before I want to tell anything, did you tell my dad about something and that made him distressed and he called me? Was that you, the doctor?
I can see your frustration, sir, and it's tough moments actually, but
I don't know. I've not told anything else. I've just wanted one information. Yeah. Are you the doctor who told my dad something serious?
Well, Masusa, we are all responsible for dad's condition and the future management. And I'm here today to address that with you and discuss with you next management plan. I can see your frustration, and it's totally justifiable.
Why can't you wait till I come over there? I'm just coming anyway. I'm on my way. So why you have to discuss with my dad without me? Is there an absolute necessity there?
I appreciate your concern regarding this. Well, our duty that as long as your father's condition, he is competent and he has the right to understand his medical problem.
Are you saying I don't have a right? Are you saying I don't have a right to ask? I don't have a right to be there?
You have the right, Mr. Sir, but we have to make sure that he is already known about his condition and he give us the consent for even discussing his medical problem with you. I can see this is a complex situation, but let me discuss with you what we are going to in our discussion today.
Okay, whatever. Yeah, tell me, Chief. He told me that somebody told him he's going to die.
I'm really sorry for this bad news, but this is not like what we mentioned to him. I would like to clarify this more with you. This is a very sensitive issue, but we need to discuss the situation. May I know before I'm going to discuss the management with you, how much do you know about your father's condition?
I know he has got like a cancer of the lung, and then he was admitted with severe back pain. And after that, I don't know, because he told me He didn't tell me anything. He just like a doctor came and then told I'm going to die. And then can you please come? Because I've told the nurses in the ward they'll be coming today in like half an hour time. And then nobody cares to wait till I come. What's an urgent, dire need for you to discuss with him at this minute?
Well, I'm very sorry that we didn't contact you early, but once he showed that he is distressed about what we said to him, we discussed the situation with you now. So, what do you expect from our management with him? Are you expecting an active treatment?
I don't know. All I know, my dad is distressed and somebody told that he's going to die.
Well, I'm afraid.
I don't know. You tell me what happened. Okay. Why is he having back pain? What's the problem going on?
Yeah. Well, I need to discuss with you something concerning about his medical problem, and I'm afraid to say this is bad news. Well, he has got an advanced stage of cancer. We diagnosed a cancer lung, okay, and this is unfortunately spread to the bones as well. And for the moment, we discussed our management team discussed the situation and assessed him, and the plan that there is no actually an effective active treatment for this cancer. Are you following me?
No clue. You didn't allow me to talk. You talked for nearly 2 minutes.
I'm really sorry. I know this is maybe a long story, but I would like again.
So you said the cancer is spread to the bones.
Yes. I'm really sorry to mention that, but he has got an advanced stage of the cancer, and it's spread to the bones as well, and this is responsible for his back pain. So the management team, who has when assessed him, found that there is no active treatment will be suitable for his condition. However, I assure you, we put another management plan in his best interest, and most of our patients who have been diagnosed with the same disease and at the same stage, they are on this management plan. Are you getting me?
So what do you mean when you say active management? What do you mean? So does that mean, see, when anything happens, we should have a treatment, isn't it? In this scientific era, when anything happens, you should have a treatment. You can't say there's no active treatment.
Your concern is justifiable, Ms. Sarah. However, in such advanced stage, I mean by that there is no active treatment that we cannot provide, like, for example, drugs that may control the spread of the tumor, of the cancer cells, or giving us surgery that may cure his disease. So as long as we don't have an active treatment, our main strategy now is to have a good control of his symptoms and easing the symptoms that he has.
So you said you can control the spread of the cancer. Can you control further spread of the cancer?
I'm very sorry. What I mean, controlling the symptoms, not controlling the spread of the cancer. So I mean, if he has a pain, we will address that and give the appropriate treatment for this pain. Okay, so this is the aim of what we are calling the palliative treatment. And once we approach him, discuss the situation with him, he got distressed. I'm very sorry to mention to you that. And I'm here today.
I know. I know. Palliative means just giving up, isn't it? Just giving up. You are giving up on him. I'm not going to give up. You are just giving up. You're just giving up on him. So what's palliative then? You said you don't do anything. So what does that mean? What's the point of him here in the hospital?
Yeah. So the palliative treatment is a holistic approach of care, or what we are calling comfort care. They are delivered to the patient, and not only to the patient, to the relatives as well who care after the patient. When the patient diagnosed with a disease, it's not curable, okay, and in advanced stage, the aim point of this management is to easing the symptoms and improving the quality of the life as much as we can. So this is the aim of the palliative treatment. You got me?
Okay, I'm told that's a giving up, and you started explaining how you come to the conclusion to give up on a patient. That's okay. That's okay.
Mrs. Sarah, peaceful.
Tell me, this is not giving up. Tell me, explain me. It's not giving up.
Of course, we not give up. We as vigorously as we can, giving the appropriate support to your father's condition, and this advanced stage of cancer. It's although it's a shortening life disease, actually, and he has advanced stage of the cancer, but we are doing our best to ensure about his comfort and controlling his symptoms. Mrs. Sarah, I know this is tough moments for you, but Pisho, we are here.
I know why is he distressed, because what I know exactly what you would have told. You would have told
Yes.
him your cancer has spread, there's no treatment, we're just giving up, no need to worry, and that's what you've told. Who won't be distressed? And that's what I don't know what you people are doing.
Mrs. Sarah, I'm not saying that we give up. This is a type of care. This is an advanced care planning we provide to our patients who have got this advanced stage of diseases. Once we are not going to treat the condition, we are aiming for controlling the symptoms and improving the quality of life. And I'm very sorry to mention this cancer. It's an advanced stage now and may affect his life. And that's why we discussed this situation with him sensitively as much as we can. And
it doesn't look like you discuss with him sensitively, or else he won't be distressed.
I know this is a shock information may be given to the patient, but our duty to be open and honest with our patients, and they have the right to understand about their medical problems. But mainly ask you some questions about his social background. Maybe there is something make him distressing while we are trying to approach him about that.
Okay, so, go.
Well, may I know with whom he is living with?
He lives alone.
And is there any social package of care just following him?
No, because I live just 2 streets nearby, so I do most of the care. I don't live with him, but I do most of the care.
And have you expressed before any obstacles? How do you cope? I mean, at his home, is there any problems?
Until the pain, he was okay, but with the back pain, who can cope?
Yeah,
the back pain is the worst one. So nobody given him any medications for the back pain. I don't know what you're going to do with the back pain. What medications are you going to give him?
So be sure that the pain will be controlled as much as we can with a certain medications, specific medications in such cases. They are strong medication to control the pain. And also this will be followed with a pain management team as well.
So who's the pain management team? Who's the team? What are they called?
Well, this is one of the specialist doctors and specialist nurses as well, who is he can address assessing the pain severity and assessing the response of the patient to the pain management we are giving to him. Okay, and this is one of the members that are involved also in the palliative team as well. Beside other members, as I discussed with you, the social package of care, we can involve the social workers and also the Macmillan nurses. They can be involved with special carers. We can care after him at home. Okay, so as much as we can, we aiming to facilitate how he cope at home at this stage, and also the palliative care. The palliative care, it's not only provided at hospital environment, we can also provide it at the community as well, under the supervision of the community services. Are you getting me?
Yeah, it sounds a little bit convincing now.
And I would like to raise a sensitive issue also with you. We advise most of our patients who have been diagnosed with an incurable illnesses that may affect the survival of the life of them to to address their wishes or to document their wishes. This will help us in the future also to keep with their wishes. And
he doesn't want to be here. He wants to go
home. We accept that as the be sure. We will not even work against his wishes, but our priority is to be sure that he is comfort at his end of life.
Okay. Then what? Where do you, so is he seen by the palliative? You said the team. Is he already seen by or going to be seen?
Well, we take a consent from him directly to be referred to the palliative care team, and as soon as possible, they will have a chat with him. The responsible team will have a chat with him.
Okay.
Okay.
Is there?
May I know if you have any?
What about the surgery?
Well, Mr. Sir, in such cases, surgery is not an option in the management. It will not benefit the patient, and your father's condition as well. It's not the appropriate treatment. So there is no possibility.
Time is up. 1 minute to collect your thoughts. And again, doctors who are listening, you can just collect your thoughts on the communication, conversation, and what type of questions the examiner might ask. So the 5 minutes before the scenario and the 1 minute before the examiner are the key time. So you can collect all your thoughts, and then maybe you can take notes and prompts and things and be ready to fire off the answers when examiners are asking you. Okay, time's up. The examiner time starts now. How did the consultation go?
Well, so I tried my best with Mrs. Sarah to trying to calm her, because she was really upset about what her father told her about his condition, and addressing with her our next management plan of the palliative care, and there is, as long as there is no active management is planning for.
Okay, what are the ethical issues here?
So ethical issues here, the autonomy, Mr. Garry has the right, of course, to understand and accept the management plan, or refusing the management plan addressed to him, and also the daughter has the right, as long as the father contact her, to know about the progression of the disease and the management plan. And the beneficence here is to do the best for the patient. So we provide the palliative care management and ensure about the comfort measures. The non-efficiency, that there is no active treatment and there is no rule for surgery, as she discussed with me. This will be harmful for the patient. And we treat all our patients equally, regardless of the financial, religion, or the ethical issues.
Okay, with the likely prognosis of short weeks, what other things would you consider if you have more time?
So any family arrangements, I try to establish that with her, and
if you have more time, what are the things you could have asked?
Yeah. So maybe try to explore more about his social background, like are there any financial obstacles, uh, any family worries he got. And also I would like to raise with her the end of life care. I would explain to her that at the near end of life, the management will be more focused on the pain control, comfort measures, informing about even the psychosocial support for the family members and to the patient as well.
Okay. What do you think the CPR status would be here?
This would be on a plan that I need to address more with her in the end of life care. So there will be no benefit if things go. This is expected actually, that the heart may stop. So there is no benefit to go for CPR.
So are you telling me you go for DNA CPR?
I didn't want to discuss this issue now with her, rather than establishing her idea about the palliative
Not
care.
with her.
And
in general, what do you do in this situation? What do you think the CPR professionally? What do you say CPR? Is it for CPR or DNA CPR?
And for his case, of course, it will be in best interest for him to not attempt resuscitation.
Okay. And if she asks for CPR, what do you do?
I try to explore with her that there is no benefit to go for CPR, rather than it will.
If she's not convinced with their explanation, what do you do?
So I will involve one of my senior colleagues and my consultant. He would be in better position to address that with her.
If she's not happy with the consultant, what do you do?
As long as it is a pure medical team, pure medical order, I think we can involve the legal team in the hospital.
Okay, thank you. Time is up.
Thank you.
Right.
Nice discussion. Thank you.
So you can totally come off the candidate role. I'm off surrogate role, examiner role. How was it?
As for me, I tried my best today, but it's a tough scenario because Mrs. Sarah, when I tried to talk with her firstly, she was very angry and tried to calm her. And she asked me difficult questions really from the start. I feel some difficulty to address the palliative and to go down the end of life care. So
is that expected before you start the...
Really? No. I was expecting that she may have a raising voice, but not to be in much aggressiveness. Really, it's good.
Okay. Right. And she asked about, right, we'll go one by one. Because you in terms of good things, say any scenarios, and this is not only for this one, and even when you practice with your study partners, the first thing first, we tend to spot only the negatives, but don't do that. The first thing first is discuss about what went well, what was good in the practice or scenario. Then you can point out, because and then I've noted down in terms of plus and minus. I've noted down everything in there. So that's the way you need to practice. So the first, I would say, positive thing is you didn't raise your voice anywhere. You're very calm and quiet and composed. And then your pace is a neat. It's not very fast, not very slow. And your voice doesn't fluctuate at all. The reason I'm telling this is when somebody is raising voice against you, irrespective of what the situation is, naturally we tend to raise our voice. But we need to have a good control about it. And that's a fantastic skill you must get the voice steady. And then when somebody is speaking fast, again, we have a tendency to speak fast as well. If somebody says, are you telling me? What do you want? Are you telling me? We said, no, it's not like that. Did you told that? No, I didn't tell that. So it's quite common. It can happen. And if you miss the emotional ability and things, it can happen, but those things didn't happen to you. That's a fantastic skill. I would say that's the biggest plus for you in this scenario. And then each and everything, yes, you explained, and then you go back. But the surrogate even bullied you to say, why do you explain more and more? And then I don't want, but that's okay. That's okay. Say how many times people tell anything, I'm not going to hear you. You are giving a waste of time.
Yes.
Anything they can tell. But
I was
we
afraid.
follow
Yes, you got worse.
yeah, we should follow the same thing. Go back and then explain. You can explain more and then check the understanding, but it's not like not to get personally frustrated against. Okay, well, I'm doing so well, but why surrogate is not happy about it? That's not the case here. If the surrogate is not happy, how we are going to manage? That's the skill that's needed in similar situations. And now coming back to the things to improve, I think you said a bit bad news.
I said bad news. Yeah, I'm concerning that I will discuss with you, and I'm afraid to say some bad news. Yes.
Some bad. That's why I say there's no some, there's no bit. Bad news.
Bad news. Okay.
Bad news. So if we say some or bit, and then you are reducing the intensity of the bad news. So bad news is bad news, whether it's for you or me or anyone, it's a bad news. So you can say, I'm so sorry. I've got some bad news, unfortunately, and then a pause. So you didn't pause at all, actually. Whether you told about, yes, I've got the bad news, and then you didn't pause. And after that, then that's where the surrogate bullied you in terms of you spoke for 2 minutes, and then you ask me what understanding. That's not the best way to do it. So whenever you do any bad news, always pause and then wait for the reaction. And then only you need to see, like, is it sinking in? And then any questions or anything like that. So that's the one little thing you need to improve on. And the next thing you said, we are doing our level best, or we are doing our best. Again, when anyone is angry, if you tell that the same thing, we are doing our level best, that's not going to make them calm down, because she's asking, you have not done good. And then you are saying, yes, I'm doing good. But you didn't raise your voice, the pace and everything is fine. But that phrase itself can irritate some people.
Yeah. So it's better.
Either you can avoid that, or you can say, we will do our level best to make things better with the symptom control and then the good quality. We will do better. So you're not saying you're doing bad, but once you sneak in that we are doing our level best, means it sounds a little bit odd. As a surrogate, I felt like, what? I'm telling you, you didn't do well, and you are telling me you're doing well. But even though you said nicely, that statement, if at all, can be avoided. It's better in terms of communication.
Better, yes.
Get the thing over there. And giving up. What is your explanation when people challenge you? Say, like, you are giving up on my dad. How do you explain? I don't think you did explain. You just stayed away from that question. How do you explain?
I was shocked about that, but I answered here. Well, this is not the situation. We didn't give up about your father.
What's the difference between giving up and acceptance?
So the management plan that we provide in his best interest is aiming to improve control the symptoms. And I mentioned that ensuring about his comfort at the end of at this advanced stage of cancer. That's
okay, right. I'll tell you now. See, in generally, to understand professionally, giving up means there are plenty of options, but still you don't want to go and choose the option. That's giving up. Let's say somebody is depressed. You tell them, okay, have this medication, and people say, no, I'm not going to take it. See, that means there is an option. We are telling them, yes, there are options 1, 2, 3. And in those situations, if people say, I don't want to have it, then you can say that's giving up.
Okay.
But acceptance is you don't have any options. Unfortunately, you don't have any options. And then you accept in terms of treatment, yes, there are no treatment options. But at the same time, you are trying to say we treat the symptoms. We can't treat the cancer or the disease, but we can treat the symptoms. So that's a kind of a positive phenomena. Giving up is a negative phenomenon. For giving up, there is no after question. They'll just say, no, I'm not doing it, full stop, that's it. But we didn't say that. When we say this, I'm telling you to get the understanding first, and then you can explain in a different way. You can explain the patient the same thing. Say, no, we are not giving up. We are not giving up here. Unfortunately, there are no options left. So we are not.
Yes, Professor. So I wouldn't say that we have to accept that he has got like advanced stage of cancer.
I don't say that. I don't use the word accept here.
Yeah, I'm saying that I didn't. Yes, yeah. When I think about in my mind, rapidly I skipped that because I think this will irritate her more.
Yeah, it will. It will irritate anyone if you say that. But the other way, you can say, no, we are not giving up. So I told you only there are no medications or the options to treat the cancer, but there are loads and loads of options to make him comfortable.
Yes.
You said, isn't it? Symptom control. So what she's asking in terms of oncological treatment, yes, we don't have any options at the moment, which is going to benefit him. See, that you can add a tag. If you say there are no options, not appropriate, that's a bit of blunt end. People will think, okay, they're all there, you are not giving. So you can say there are no options in terms of treatments, which will make him benefit as a whole. Because any treatment is not without side effects. If you do anything, if he's frail and things, and it's not going to benefit anything, you can say. But I know in this situation it might be difficult. But if the surrogate is not angry, if the surrogate is in the listening mode, you can explain all those things just to change the communication style or the phrase so that he can. These are the things you can say. When people can, that's the commonest thing I would say. Being in palliative care for nearly 20 years, that's a commonest thing. People would say, okay, you have given up. And then we will usually tell them in terms of, no, I'm so sorry that you feel that way, but we are not doing that. So we won't give up in making him comfortable at all. So we'll be the first person to give anything and everything possible to make him comfortable and to have a good quality of life. So all that, what we are saying is, unfortunately, there isn't any treatments available for extensive cancer. And that's what we are saying. Then you can say, I'm not saying in this situation you could have told, because when the patient is angry, you can't tell anything like that. But when the situation calms down, you can tell that. One more feedback. Pain management team. See, pain management team, when you say pain team in hospital setup in the UK, they are acute pain team. The background is anesthesia and all anesthetists, and they get trained in pain management with acute pain management. But if you say pain management team, that will focus on them. But the other way, you told the palliative care has got one of the members of the pain management team. It's not like that. The palliative care team itself covers the pain management. Holistic care includes like a physical care, and physical care includes the pain. Say, I'm a palliative care physician. So I wouldn't say like I've got a special like a pain management title. No. When I say palliative care physician, I do get trained about pain management. I do get trained about holistic assessment, psychological assessment, spiritual assessment, everything.
So I mentioned, yes.
So not to mention pain management team in end-of-life care situations, because if you say pain management, that indirectly or directly refers to the acute pain management team, who are anesthetists with a special training. So they do like a nerve blocks and thing. They give medication as well, but they are different.
Yes. So when I addressed with her that we will give her strong medications that are given in such situations, should I mention exactly we are giving like medications like opioids, or just about mentioning it's a strong medications, will control the pain, and known to be prescribed in such advanced stages?
Yeah, you can tell. Yeah,
that's good.
You can tell. Yeah. So there are plenty of medications, and there are some strong medications out there, so which other specialties won't be able to give, but we can give.
But no pain management team.
Yeah, pain management, palliative care team can do. So you're not going to give personally. In your situation, you're going to discuss with the palliative care team. And palliative care team or the specialist team, they can give stronger medications. They can prescribe whatever needed. So we will make him comfortable. So if you tell that, That's it. And that's why it's not giving up. You're telling no, and then you are going to the other end. And DNA CPR, you're 100% right. Yes, DNA CPR, it's definite. Because you said like there's no time. See, again, I have seen you. There's no time in terms of as an examiner, so no need to explain. Go back again. And all that I asked in terms of if you have time, what do you do? So the straightforward answer, if I have time, yes, I would have asked for some more things in terms of preferred place of care, or preferred place of death, advanced care plan, power of attorney. And she said she wants to go home. That means you could have explained in terms of why is that, as you explained anything before. So is it doesn't like the hospital and go home, or does he want to die at home? So those things can be explored, but not in this situation because you're dealing with an angry relative. But if they're not angry, those things will come into play as a package.
Okay.
So if you're talking about palliative end of life with the short weeks of prognosis, everything will be set in order 1, 2, 3, 4 like this, including the CPR.
Appreciate.
Okay. Right, that's lovely.
Lovely, yeah.
Right. Okay. So any
Fruitful
questions?
discussion.
Yeah.
I really appreciate your effort with me, Dr. Ramesh. Yeah,
No
you push me forward, really. Thank you.
Any other questions from anyone? Either you can ask or you can chat. You can mention in the chat. Or you can raise your hand. Any other questions from anyone? I'll give roughly a few seconds to see. Right. Okay, then. So if there are no other questions, I'll just summarize. In this scenario, that the theme is, yes, palliative care, and then like an end of life care, because it's short weeks. End of life care is usually last 1 year. And if you're talking about short weeks, that another, again, it's a breaking bad news. Then don't forget about giving the news and then give a pause and then wait for the response. Then here the added point is the relative's collusion, actually. Relative is saying, okay, don't discuss with him without me. And why did you discuss with all those things? Can I think someone is not muted. Can you mute? Okay, right. So that's the collusion here. And again, we need to explain in terms of the other thing I would have said, see, in this situation, yes, it didn't get time. You didn't get time. But if the time is there, the only way to do is, see, we can generally apologize because Dr. Nawaz said, oh, we will discuss in a sensitive way. And immediately the surrogate say, it doesn't look like that. And then you can say, oh, I'm so sorry. If he has taken that way, we can go together. I can come with you. And then we can go together and then explain him in a sensitive way. I'm so sorry if you felt that way. If you told that, you come down actually. You told that, but you told a little bit late. And initially, when somebody is asking distress, well, you're asking them, no, we did the right thing. I don't know why he is distressed. That's not the way to answer. The way to answer is, I'm so sorry, get distressed. So I'm sure we would have done sensitivity, but it doesn't work this way. So we will come with you and then we will go again. And then if he has any questions in front of you, we'll explain, we need your help. And sometimes they say, I know more than you. You have to accept it. We have to accept it. As when they say, I know more than you, oh, yes, that's, and then get them on your side. Oh, yes, I agree with you. So we need your help. And then shall we go together and speak to him and then see how things go, kind of things. So anything is like a negotiation helps. And the last one is give information like in small chunks, because once it's like a train of thoughts and you will be expecting to finish the task, but that doesn't help some way. So get the task. First of all, here is relative is angry in terms of why did you tell him? Sort that issue. Then you go to the palliative care. Then you go to the end of life care. Then you go to the explanation. If you have got time, then you can go to the preferred place of care, preferred place of death, and then power of attorney, DNA, CPR, everything, and the good closure in terms of keeping people comfortable, quality of life, and it will be perfect.
Yes.
Okay. So one more time before I finish, any questions or anything? No, that's okay. Thank you, everyone. And